psychosis. And along the lines of investigating whether or not a general medical condition or GMC might be manifesting behaviorally instead of physically, we first investigate whether or not in the film, or in the case of Sleeping Beauty, perhaps even the book, whether or not the author actually writes a GMC into the narrative. If they do, certainly that is synonymous to a patient in real life, providing you a very direct history of a medical condition that certainly then can be the cause of their behavioral disturbance, including psychosis. On the other hand, what often happens both in film and in real life is that you don't get that, you don't get that clean history. And when in a clinical setting, you don't get a clear history of a medical condition that could be inducing the behavioral disturbance, such as psychosis, you have to ask yourself the next question. And that is, does the absence of information reassure you that therefore no GMC is inducing the condition? And this is not an easy question, and there is no simple answer. The bottom line is that it really will depend on the type of practitioner you are. What you see on this particular slide is that we look closely at risk factors. Okay, we definitely look closely at risk factors of underlying medical conditions. And again, we'll bring this out of the case of Aurora and bring it into a real life situation. An individual may present with a chief complaint of blank. Again, to keep consistent with our example, let's say it's psychosis, or we could even say it's a sleep problem like insomnia. And we'll ask them, do you have any medical conditions that you're currently being treated for, perhaps through your primary care physician? No, I am not. Well, the validity and the utility of that question, quite frankly, is only when a person tells us yes. When they tell us no, sometimes we have to assume that there's still a medical condition there, despite they're not being treated for it. That is, maintaining that high clinical index of suspicion. Now, that index of suspicion is highest in older males, right? So if you look at the bottom of your slide, the answer here would be no, when both risk factors are in play, that is a plus plus. You should not be reassured as a clinician when a patient simply tells you no to any history of a medical problem. That is not reassuring when the individual manifests with two risk factors, that is being older and being male. On the other hand, it is relatively reassuring, and this is now the second bullet, yes, when the individual is both young and female. The absence of those two risk factors are such that your clinical index of suspicion now is much lower. And of course, there's two intermediates. For older females and younger males, in each case, in each cohort, the individual will have a single risk factor. And whether or not you go forward with a workup of an underlying cause, routine lab work, et cetera, or not, has everything to do with what type of healthcare provider you are. If you're conservative, you might not go forward with it. On the other hand, if you are continuing to operate with a high clinical index of suspicion, because that's the type of practitioner you are much more likely to order blood work, et cetera. And this is just a quick list of those conditions that can induce, as the title of the table above says, delirium. The same holds true for psychosis. And then finally, the other exclusionary criteria include schizoaffective disorder and mood disorder. And the only question here really is whether or not there's a significant mood component to the patient's illness. If the answer is no, there's nothing further to do. However, if the answer is yes, you have to consider that their psychosis may be a manifestation of a primary mood disorder, or it may be a manifestation of another psychotic disorder called schizoaffective disorder. And if that is the case, schizoaffective disorder will replace schizophrenia. as the single best answer, that is the most likely diagnosis. Now, we're applying this to Aurora, but I want everybody again to appreciate the algorithm we just went through so as to actively apply it while you are watching Dr. Sleep later on this morning. The final step in how we help patients and consumers identify an illness and therefore prepare for a biopsychosocial treatment plan is this final exercise. If, hypothetically, you took notes during a film, or if you want to bring this to real life, when you take notes in providing a patient history, if you were to cross off all of your notes that are explained by everything we've already discussed, the algorithm we've already went through, would there be anything left on your paper? That's the bottom line. If the answer is no, then all the different conditions that we just went through must in some way satisfy your patient's experience, whether it's depression, whether it's psychosis, whether it's sleep disorder. However, you could then see that if anything was left not crossed out, you have more explaining to do. You can't simply tell a patient, you can't tell a consumer, well, you know, this is unexplained. And given everything we just discussed, I'm sure somehow it accounts for what you're struggling with. That's just not going to fly in clinical practice. So this final exercise, if something is left uncrossed out, if that's actually a word, requires us to think of a differential diagnosis. That is, what other conditions must we consider to explain away your remaining symptoms? And that's where, if we focus on Aurora, I think it's very simple. She sleeps a lot. I mean, this is someone who at 16 years of age goes into what appears to be a very deep sleep. And in as much as a lot of her other behaviors might be explained by all those other conditions that populate my previous slides, that prolonged period of sleep simply doesn't. And if we're going to analyze Aurora, if we're going to analyze and case formulate Sleeping Beauty, we better focus on her hypersomnia because that's simply not explained by any condition we've discussed. And that's how we get to the focus or the topic of today's discussion. Let me briefly pause upon completion of this algorithm. Again, I wanted to model it because in reviewing these slides during the movie, if you begin to apply what we just did while actively watching Dr. Sleep, or quite frankly, any other movie you choose to watch, it is a wonderful way to analyze what might be going on behaviorally in your fictional patient, that is your protagonist or antagonist in the film you choose. So now that that algorithm is completed, before we get to the next set of slides, any questions from anyone? I could tell you that we do the same exact thing in real life. Many of you know I work on a consult service. And the way a consult service works is that myself, my team, are in our psychiatry suite. The phone rings. We have a patient's last name. We have a room number in the hospital, and we have a reason for consultation. For instance, it could be hypersomnia. It could be psychosis. It could be anything. The primary team, whether it be a surgeon, pediatrician, doesn't matter, has questions that need to be addressed with regard to psychiatric acuity in the general medical hospital. The first thing or the next thing that occurs is that the medical student provides a initial evaluation. That includes a chart review. That includes speaking with the person who made the consult request. Can you fill me in what's been going on and what questions can we answer for you? And that also includes a comprehensive psychiatric evaluation. They spend up to 90 minutes to 2 hours with a person at bedside and go through a routine psych eval. Following that evaluation, they get their notes together and they have to present their case back to myself and the group as part of a case conference type of setting. And in that case conference setting, the last 10 or 15 minutes are the practical application, or is the practical application of the very algorithm that I just reviewed with you. Now, they don't get the benefit of seeing the slides, but I will take them question by question that the slides just highlighted. And ultimately, they'll come up with the most likely diagnosis, and that includes the differential.
Dr. T, could I ask a question?
Of course.
I'm curious, when you're talking about that potential scenario, are hospitalists very good at making those referrals, since they're the people often that are seeing someone inpatient, or is that not the experience?
So that is my experience. However, in answering yes to your question, there's a bit of a caveat, and that is because of where I sit in the process, I don't have a great feel of the overall number. So I know only of the requests that come in. There's no way for me or my group to understand what the true need is. So I can sit here and tell you that, we do on average, let's say 15 to 20 consults a day. And that might sound that since the majority of those are coming from hospitalists, that might sound good, and perhaps it is. But hypothetically, if you told me that the need was 80 a day and that 60 were being missed, all of a sudden you could see how my numbers would have been skewed. So I think it's good, but that's only from where I sit. To get a real accurate answer, I would really need to know the overall need to get an idea of what fraction or percentage are in fact coming our way.
And in the rounds that a hospitalist is required to do, are they doing a psych round so that they are prompted to think of this?
They are not. No. This is still working in the tertiary care model, where if you walk into a room and the patient's behavior overwhelms you as a primary provider, then you think, hey, let me call psych. Only in specialized situations, for instance, our emergency department, you have routine screening where a person who would be asymptomatic might still come to the attention of a psychiatrist because of routine screening. Suicidality is a great example. Screening for suicidality and suicidal thoughts in our ED is common practice, right? That's a model that has been employed by our hospital. Similarly, no one who gives birth to a bouncing baby girl or boy leaves our hospital without getting a depression assessment. So again, that's standard. But those are the only two, I think, examples of when asymptomatic people are screened and might come to the attention of a psychiatrist, or specifically my CL service.
Thank you.
Can I ask, and I'm sorry for the dogs barking. I'm downstairs and they're upstairs. I locked them up there. Where do comas come into this? I mean, like even induced comas.
Yeah, it's a great question. I think to first answer your question simplistically, the coma would be designated as an example of a general medical condition that would explain the hypersomnolence. Now, again, if a neurologist was at bedside, or better yet, an intensivist, somebody who actually rounds in an intensive care unit, were to tell me, hey, doc, there's no physiologic reason why the individual is appearing comatose, then if they're telling us, if the medical doc is telling us that this isn't a coma, then there's more work to do. But if coma is ruled in and there are bedside maneuvers to diagnose a coma, it would fit under that general medical condition that would need to be investigated and evaluated before saying that the patient's unresponsiveness and apparent sleeping was due to a mental disorder. All right, so let me start this next slide. Again, I know our film today is going to focus on Dr. Sleep. What I put here is a list of Stephen King films right side of your slide that also deal with sleep, right? So Boogeyman, Dreamcatcher, and Sleeping Beauties. Only Dreamcatcher is adapted to film. The other two are, one's a short story, Boogeyman, and the other one is a novel, Sleeping Beauties. So in addition to Dr. Sleep, we have 3 other Stephen King films that focus on sleep. Now, as many of you might recall, we've put together a pretty comprehensive curriculum called Once Upon a Time in Castle Rock, hence the title of the slide in the background. What Once Upon a Time in Castle Rock does is it pairs Disney films to Stephen King novels/films. And in pairing, we get to discuss substance-induced mental disorders. The substances are disclosed or divulged through the Disney film, and the mental disorder is disclosed or divulged in the Stephen King film. That way, by pairing 2 films, we always then could come up conceptually with an example of a substance-induced mental disorder. And the 3 films that I paired with the Stephen King films on the right include Monsters, Inc., Lilo and Stitch, and Sleeping Beauty. Now, the pairing of the films is done, how can I put this, generically, right? So if someone were to read the short story Boogeyman by Stephen King and watch Monsters, Inc., a non-psychiatrist, a non-CAS participant would say, hey, these movies have a common theme. They both deal with children in their bedrooms, scared of or afraid of what is in the closet. And anyone would pick that up. There's nothing psychiatric or psychological about that. Similarly, Lilo and Stitch and Dreamcatcher are alien movies. And then finally, Sleeping Beauty and Sleeping Beauties, I could tell you, since in Stephen King's short story, this is a novel, Sleeping Beauties, there is a worldwide pandemic that is called Aurora. The connection is incredibly straightforward, and the title strongly suggests the link between the Disney film Sleeping Beauty and Stephen King's Sleeping Beauty. So the connection is evident. It has nothing to do with us building some kind of a link to teach. On the other hand, a closer inspection of Monsters, Inc. reveals that it could be the focus of discussion to learn about caffeine, both caffeine intoxication, as well as caffeine withdrawal. Lilo and Stitch. We talked about this last semester. Lilo and Stitch, upon closer investigation, is about cannabis, specifically about synthetic cannabis. And in doing a cursory review, I didn't read it, but a review of Sleeping Beauties, that is from Stephen King, there is a very straightforward plot narrative of multiple drugs, including stimulants, alcohol, and sedative hypnotics. Now, what's interesting is that while we haven't addressed hallucinogens, inhalants, and opiates, the substances that are taken from these Stephen King novels on the right side of your slide have one thing in common, and that is they all can induce sleep difficulty. And if you want to remember the substances that have been left out of those particular Stephen King works, the acronym is HI-HO. And even though we picked Aurora as our initial case example, I think everybody would agree that Snow White also has her issues pertaining to hypersomnolence. So ultimately, we get to the focus of today's seminar, which is insomnia, the sleep-wake disorders. I think one of the first things I want to mention is that the American Psychiatric Association has come up with 3 new terms. This is on the right side of your slide with regard to insomnia. Initial insomnia is defined through difficulty initiating sleep. So difficulty falling asleep, initial insomnia. Middle insomnia, difficulty staying asleep. And then finally, late insomnia, early morning awakenings. Right? So initial, middle, and late insomnia are 3 new clinical terms that have been adopted by the American Psychiatric Association. I'm not going to really get into waveform in any real detail today. I did want to bring up some names so people are, I think, become familiar with these. Now, again, don't worry about the number of hertz. Don't even worry about what a hertz is a measure of. I mean, forget that. However, what I want you to appreciate on this slide is how rapid that is. I mean, it's a lot of squiggly lines. If you want to just take 1 inch or 1 centimeter, you can see how frequent, that is the frequency of these, what are called cycles. I mean, how much? And there's a lot here. And the reason why is because your brain's very active. So this is called the beta wave. Again, I just want you to recognize the name. And what you should know is that the beta wave is the characteristic brainwave when an individual is awake, alert, and actively paying attention. I would hope that if we put EEG leads on any one of our participants right now, it would show that you are in the beta state. You're actively listening, and therefore your wavelength would be very similar to what you see at the top of your slide. On the other hand, if you begin to zone out, you're going to go from beta to alpha. Okay, so this is just that. It's just zoning out. And you could see that these are much less frequent waves. Again, the fact that they're between 9 and 13 is irrelevant, and the fact that we measure wavelengths in general in hertz, equally as irrelevant for us today. I just want you to know that it goes from beta to alpha. Don't ask me why it didn't start with alpha and go to beta and just simply follow the Greek alphabet. I'm clueless there, but somehow neurologists require us to remember that beta comes first and then alpha comes second when people begin to zone out.
Dr. Tobias, I have a question. I have a lot of patients, especially teenagers, kids in college, that say they often have a feeling of like just disconnecting or disassociating or like floating. So I guess the alpha brainwaves are taking over, whether they like it or not. They're in school and they say they just feel like they're not there. Is that any indication of a mental illness, or are they just tired?
Right. So, and again, the easy answer here is yes. So what the brain, I know, right? What the brain waves signify is that state of the brain. Now, why the brain is in the state that it is still a toss-up. It could be that just the night before, that person just did not get a good night's sleep, and it could be as simple as that. However, to your point, when it becomes recurrent, it's usually something different or something extra. Again, what that extra is still a fairly wide differential diagnosis. It could definitely be due to a mental disorder, but then again, it does not necessarily have to be due to mental illness. So I would start there, though. Remember, anytime we think that something might be due to a mental illness, we must always investigate the chance that it's due to either the direct and physiologic effects of a substance or an underlying medical condition. So that's where I would start. Are they currently taking any medication, antihistamines? Or are they using drugs? And if the answer is no, and we could take that off the table, then let's talk to their pediatrician. Let's talk to the primary care physician, family practitioner, and get an idea if they've been given a clean bill of health. And if the answer is no, if no there, that is a medical condition is not explaining what's going on, then the third step is to consider a mental disorder. So that again, that's always the algorithm. It's always the stepwise approach.
Okay, thank you.
Theta is next. Okay, so theta is next. Again, I have no idea why they skipped over the alphabet here, but theta is next. And what theta basically is the interface between wakefulness and sleep. That's all it is. It's the transition and going to bed. That's theta. Now, once you process through theta, you're sleeping, and there is unconsciousness, right? So sleep is an example. That is, it is an etiology of unconsciousness. When somebody is asleep, they go through different cycles. And what you see on this slide is an example of a cycle. A cycle is always made up of two components. There is a non-REM portion followed by a REM portion. And at the completion of that REM portion, the individual will have gone through a single cycle. And people cycle through the night. They cycle from 11p to 7a when their alarm clock goes off. You'll also notice that during the non-REM period, there are mini cycles. We usually discuss them in terms of stages 1 through 4 of sleep, but in clinical medicine, stages 3 and 4 are always combined. And again, I just don't know why we don't call it stage 3, but we've kept with the original descriptors. So stage 3/4 sleep is the third and final substage of non-REM.
Doctor, sorry, I have another question. If someone is taking Ambien or Trazodone, like long-term, are their stages of sleep different? And does it affect their mental health? They possibly become depressed or anxious due to continually taking sleep aids?
Yes, possibly. And yes, possibly. Yeah.
I just wonder if they go through those proper cycles and get restorative sleep, or are they not, it's like fake sleeping.
Yeah. For lack of a better word, there is evidence that there is fake sleep. So they might be unconscious, but they may not be cycling correctly. And therefore they could often awake in the morning complaining of non-restorative sleep. They can definitely do that. And to the extent that an individual is experiencing that, yes, that itself is an independent risk factor for mental illness, including, but not limited to, the depressive and anxiety disorders. Yes.
Thank you.
Yeah. Now, I know we're going to get, and hopefully we're going to have time to get to some of the treatment slides. However, given your question, I think I want to just jump over to that topic, albeit very briefly. Generally speaking, when an individual comes in and you diagnose a sleep-wake disorder, you, as a clinician, will put together a comprehensive biopsychosocial treatment plan. So I don't think I'm saying anything right now that anybody would disagree with. As part of the biological component of that biopsychosocial treatment plan, there are the options of starting a medication, and hopefully an FDA-approved medication, often referred to as the sedative hypnotics, or maybe just hypnotics for short. These are your sleep meds. These, and one example would be the one you provided, Ambien, Zolpidem. Generally speaking, when I talk to patients about prescribing a medication like Ambien, or really any other hypnotic for that matter, I will want to know from them. I want their contribution as an active part of the treatment team. When are you getting off of this? What are we identifying is our objective, that when we satisfy that, we discontinue this medication. Now, it might be weaned. I'm not saying discontinue it abruptly, but we're going to get you off of this medication. I want part of the conversation in starting the med to include when we're getting you off of it. And if there's no clear discussion there, then what I often tell my prescribers, that's my junior faculty, and especially my residents, if you are not having a discussion of when you're stopping the med, please do not start it in the first place. Right. So that is one of, I think, a major clinical pearl to consider when prescribing these medications, because what often does happen is that individuals are on these medications chronically, and the outcome is exactly what you just highlighted. They can begin to disrupt the natural architecture of sleep, these REM, these non-REM and REM cycles, and that can contribute to insomnia, meaning non-restorative sleep, that would be late insomnia, and that itself can lend to mental illness. So something to be very careful about when you even begin to consider writing a prescription for one of these hypnotics.
And Dr. T, in your experience, what is a classically valuable amount of time for someone to be on that in order to, to restore normal sleep?
Well, yeah. So the idea here, so there's two answers to your question. One would be 1 month, and that comes from a physiologic perspective, meaning that if an individual is on a medication like a hypnotic for 1 month, and we'll continue to use Ambien as an example, when they do come off the medication, they are at risk for withdrawal. That is, the individual has become physiologically dependent on the drug. So that cutoff is usually 1 month. So that's the first thing I would discuss with patients in terms of the way your brain is going to react to this medication. You will become physiologically dependent on this medication in 30 days. So that 30-day, I think, point is one that needs to be referenced. On the other hand, from a practical point of view, if I'm hearing from you that your child is getting married, there's a lot of stress because it's across several states, there's a great expense, and the wedding is in the spring, my giving you this medication or prescription for a month is not going to do it. In a practical sense, we'll look at that wedding date as the stop date. So even though there's going to be informed consent that the patient understands that they might become physiologic dependent just at 30 days, that's a risk that's worth taking because the benefits of prescribing the medication up to that wedding date outweigh those risks. So that's part of the informed consent process.
Thanks.
Yeah. But then you could see, without a clear-cut date, identifying that wedding planning stress is inducing the insomnia, and we have a clear stop date because that is the wedding date. Not that your child is going to stop causing you anxiety after they're married, of course, but you have a clear-cut end date. How that is so much different than not having a clear-cut end date and saying, well, we're going to prescribe this and we'll just kind of, we'll see how it goes. Because that type of care often lends to the chronic prescribing of these and the inherent risk that we've already discussed in terms of a future mental disorder. Stage 1 sleep. This is just what it sounds like. It's the initial stage, so you're still going to see that theta activity. And this is the third bullet, the hypnotic jerk. This is when the person in front of you in class, and we all remember them, falls asleep and they have to jerk themselves up with their shoulders abruptly so they don't fall off their chair. Everybody laughs, but what that person just did was demonstrate to you the pathologic or the pathognomonic behavior, the hypnotic jerk that defines stage 1. Stage 2. Stage 2 is light sleep. And what often occurs in light sleep is that we can get awakened, right? I think simple and straightforward. And because of that, we see two, and now we're not gonna, we could do this. We could see a couple of things. One is called a K complex, and the other one is called a sleep spindle. And you can see examples of this here. And even though this seems a little complex, let me explain it because it becomes, I think, intuitively obvious. We have all been in some form of light sleep before. We've all been in stage 2 before. And we've all been in the situation where something, quite frankly, awakes us. In clinical terms, in neurological terms, those are referred to as micro arousals. Now, it's different than somebody actually coming over and waking you up. That's a macro arousal. The micro arousal is exactly what it sounds like, something that is inadvertent, happens to begin to awake you. That will be seen on the EEG. That's that K complex right here. You could see that spike is your cerebral cortex awakening. Now, because of the stage of sleep you are in, your brain knows that your goal is to stay asleep. This is not an alarm clock going off, right? The alarm clock going off would be a macro arousal. So your brain has a built-in protective mechanism. That is, your brain quickly shifts into those evasive procedures and begins to block out your immediate environment. And when your brain blocks out every stimulus in your immediate environment to preserve the goal of staying asleep, that shows up on the EEG as a sleep spindle. That's to the right, right? That's smudging of those lines, right? So both of these, the K complex, the waveform due to the micro arousal, as well as the following or subsequent sleep spindle, your brain's effort to have you simply roll over and continue sleeping, are pathognomonic for stage 2, AKA light sleep. Well, if stage 2 is light sleep, stages 3 and 4 must be deep sleep. And you could see the delta wave is the slowest wave. I mean, if you want to compare this wave to waves that I've showed you on subsequent slides, clearly, this is a very slow waveform. Stages 3 and 4 sleep are the deepest sleeps. This is when you try to wake your son or daughter up and they're not getting up. They don't even flinch when you try to wake them up and you come out of the room and say, hey, so-and-so's still sleeping. They're not getting up. That's slow wave sleep. The slow wave is called delta. That's delta wave sleep. And that is the most restorative sleep. That takes up, that is non-REM, 80% of your sleep time. The remaining 20% of total sleep time then is REM sleep. Most of REM occurs in the final third of the night, and during REM, we dream. And during REM, so as not to act out our dreams, we have what is referred to as skeletal muscle atony, which is sleep paralysis. We're paralyzed while dreaming, and that's normal. All right, so we are exactly at 10 o'clock. I want to take a 10-minute break. Everybody stretch, and we will begin reviewing the different sleep-wake disorders when we come back. As we come back from break, does anyone have any questions about anything we've covered up until this point? All right, well, I'm going to share my screen and we're going to begin to review the different conditions that make up the sleep-wake Disorder chapter of the DSM. So the first thing I want to review is that the American Psychiatric Association categorizes the sleep-wake disorders as either dysomnias or parasomnias. Dysomnias are those conditions that result from abnormal mechanisms that generate sleep-wake states. So here we would be looking at the different brain waves and how a disruption of those may result in sleep-wake disorders, specifically the dysomnias. These often result in an abnormal amount, quality, or timing of sleep. On the other hand, the parasomnias focus not on mechanisms, but on behaviors that occur in association with, at, or around the time of sleep, right? So again, para means around, and that reminds us that the parasomnias focus on behaviors that are abnormal, occurring at or around the time of sleep. We're going to look at the dysomnias first. And in looking at the dysomnias, I want to reference yet another film franchise. And I did mention that we would be discussing alien films, specifically alien horror, in a brief context, if only to introduce the 1951 science fiction movie, The Thing, sometimes referred to as The Thing from Another World. Irrespective of it being, I think, a great movie, the one thing I want everybody today to appreciate is that The Thing, the 1951 original, is set at Polar Expedition 6, which is at the North Pole. When you think of North Pole, especially at or around this time of year, I want you to remember that's where the Grinch lives. And if you remember that, you remember the acronym that will allow you to list the different dysomnias. So looking at those conditions that focus or are defined through abnormal mechanisms that result in difficulty with the amount or timing of sleep, the conditions that would cause that include gasping-related apnea, hypopnea, insomnia disorder, narcolepsy, the circadian rhythm disorders, and then finally hypersomnolence disorder, right? So Grinch. We'll go through these, I think, in a very brief review, just so we can highlight them and get you to remember the most important qualities, and therefore, in hope of remembering what constitutes Grinch, that is, what constitutes the list of dysomnias. There are three examples with regard to gasping-related apnea hypopnea syndrome, the GR in the acronym Grinch, and one is obstructive sleep apnea. Now, obstructive sleep apnea is a condition where individuals have difficulty breathing during sleep, resulting in several identified physiologic adverse outcomes. So this diagnosis is usually prompted by the patient themselves, and it's usually with a complaint of late insomnia, specifically not feeling they've gotten restorative sleep. And that makes a ton of sense, since during sleep between 11p and 7a, the individual has had episodes where they've stopped breathing. So it's very easy to understand why a person might present to their primary care physician with complaints of non-restorative sleep. This condition is further supported by the bed partner, who often reports incredibly loud snoring, right? And perhaps even gasping. So that's obstructive sleep apnea. Now, when the red flags are there, there's some controversy as to when to refer for a sleep study, otherwise referred to as the polysomnography. Insurance companies may not cover the sleep study, and it might have to go to physician review. So additional questions that I think each clinician should be aware of to inquire about that would increase the likelihood of obstructive sleep apnea being discoverable on a polysomnography include the following, right? And the acronym here is PowerNap. The idea here is that without these, the referral may be rejected by third-party insurance carriers. However, if the clinician in ordering the sleep study can prove these, can document these, the insurance company would have significant more difficulty in rejecting the claim. Pulmonary hypertension. Individuals who stop sleeping at night, individuals who stop breathing at night have an increase in blood pressure in their pulmonary circuit, right? So that's the cause of pulmonary hypertension. This is very similar to what we often refer to as hypertension, which is otherwise referred to as systemic hypertension. And that is an increase in blood pressure in the vasculature other or outside of the pulmonary circuit. So there's two forms of hypertension: that which occurs in the blood vessels in the lungs and that which occurs in the blood vessels everywhere else. If the latter occurs, we call that blood pressure. And a lot of us have it, especially with advancing age, and we're put on a blood pressure med for it. Well, the second kind of blood pressure or high blood pressure is that which is found in the pulmonary circuit, and that is called pulmonary hypertension. And that can be caused by obstructive sleep apnea. The O in the acronym, you have to bear with me, is other. And other focuses primarily on the cardiovascular system, C/V. Individuals with obstructive sleep apnea can have systemic hypertension too. So HTN is hypertension, and that's just high blood pressure. But another example of a cardiovascular effect is arrhythmia. So any arrhythmia can result from obstructive sleep apnea. Individuals with this condition, when they stop breathing, can toss and turn so much during the night that they perspire and will complain about waking up with wet sheets. So if you ask your patient about wet sheets in the morning, if they endorse it, if they say yes, that is evidence that they are tossing and turning a lot. And one reason that individual may do so is that they're not breathing correctly at night. They go to their back, they stop breathing, they turn to their side, and they start breathing again. That back and forth can lend to significant perspiration and therefore significant wet sheets. When your lungs fail because they stop doing their work, that is, you stop breathing, other tissues in your body are going to compensate for failing lung function. Now, the lungs' function is to get oxygen to other tissues and the vital organs. When the lungs fail, the other tissue that ends up doing the lungs work for it are your red blood cells. Red blood cells are the oxygen carrying transport in your system. Red blood cells ensure that oxygen gets from your lungs to other tissues and the vital organs. They are the oxygen carrying transport of humans. So every degree with which your lungs fail and are not nearly as efficient as oxygenating the blood the blood itself, specifically the red blood cells, will multiply so as to compensate for that. So what you are losing in quality, you are gaining in quantity. And the increased quantity of red blood cells is called erythropoiesis. Again, that's the process of multiplying red blood cells to complete their task of compensation. And the clinical syndrome is referred to as polycythemia. Polycythemia is a very fancy word of saying that you have an increased number of red blood cells. I mentioned before that stages 3 and 4 sleep is the deep restorative stage of sleep. And during this delta sleep, this deep sleep, we have several physiologic processes continue. That is, during deep sleep, during delta sleep, we have your sex hormones produced at their peak levels. If you stop breathing during stages 3 and 4 sleep, you will have a reduction in sex hormone production. And that is often manifest as a decreased or reduced libido. Individuals who stop breathing at night have a buildup in pressure in their thorax. And when you have a buildup in pressure in your thorax, in your chest cavity, you have a subsequent buildup in pressure in your abdomen. And when the pressures build up in your abdomen, they are going to pressure your bladder. And individuals will often complain of getting up in the middle of the night, having to urinate, a condition referred to as nocturia. And that all have to do with the buildup in intra-abdominal pressure that itself results from a buildup in intrathoracic pressure, which itself is caused by the individual not breathing. Individuals who have severe obstructive sleep apnea have snoring that exceeds the decibels of what OSHA considers to be a safe workplace. So if this is something that is occurring through the night, individuals and their bed partner will often complain of waking up with morning or AM headaches. So morning headaches are consistent with severe obstructive sleep apnea, in as much as the snoring that results exceeds the number of decibels that OSHA requires, that OSHA identifies with regard to a safe workplace. And then finally, there are psychiatric manifestations of people with insomnia in general, but even obstructive sleep apnea in particular, that non-restorative sleep does serve as independent risk of a future mental disorder that is psychiatric manifestation. So with power naps, the clinician can ask, as part of their review of systems, if their patient, if their consumer has any of these, and if there is evidence of insomnia, if there's evidence of late insomnia, complaints of non-restorative sleep, if there are further complaints by the bed partner of snoring, and your patient has pulmonary hypertension, has a high red blood cell count, when that patient gets referred to a sleep study, the insurance carrier is much more likely to approve it, right? So that's obstructive sleep apnea. Insomnia disorder is exactly what it sounds like. It's a person suffering from insomnia that itself becomes clinically significant, right? So if you have difficulty sleeping, do you have insomnia disorder? And the answer is perhaps. And there's two things we want to look at. Is it persisting? And does it impair your function? Persisting in the DSM is defined, highlighted here in blue. That is, it occurs about 3 times per week for at least 3 months. And with that pattern, if it causes clinically significant distress or impairment, then the answer is yes. Insomnia disorder would be the most likely diagnosis. Narcolepsy. Narcolepsy is a sleep disorder that focuses primarily in the timing of sleep. Right. So if we could just go back and let me just do this here. And what you're seeing here is one cycle of sleep. The cycle itself is made up of two components. What if this happened? And the answer is you'd be diagnosed with narcolepsy. Narcolepsy is when your cycle gets disrupted and you have REM intrusion into a non-REM state. Right? That's the main idea of narcolepsy. You'll often hear the clinical term REM intrusion, and that is a big part of what defines narcolepsy. A REM period intrudes a non-REM state. Now, what I did in adjusting this slide is I gave you an example of when REM appears during a sleep cycle where or when it should not appear. And while this is defining of narcolepsy, so too is when REM intrudes normal wakefulness. So if that happened to any of us right now, even though we are not unconscious, as the title of the slide demonstrates, we too would be diagnosed with narcolepsy. So REM intrusion to non-REM states, and that includes other sleep states, as well as non-sleep states, normal wakefulness. So when REM does this, what happens? And the answer is reflected in the DSM criteria. The acronym is CRASHED. That is, individuals who begin to REM. And again, let's use as an easy example, all of us right now or any of us right now. REM in the present during a period of what we hope is beta activity. So right now we are all in beta, and then in 3, 2, 1, we begin to REM. The first thing that's going to happen is cataplexy. Cataplexy is the neurological term that illustrates or defines a drop attack. So individuals with cataplexy will have the acute onset of paralysis. Remember, when we REM, we become paralyzed. That is our brain's own protective mechanism that has been developed evolutionarily over generations. If we begin to REM, we must go into a state of paralysis. And when we are awake and alert, that will result in a drop attack. And that drop attack is referred to as cataplexy. Remembering, part of the pun, REM being the pathology that defines narcolepsy, the R in the acronym stands for REM pathology. Narcolepsy's onset is usually in adolescence. If REM occurs during sleep, especially the lighter stages of sleep, you'll actually experience sleep paralysis. Again, when that happens, when you're awake and alert, that itself will result in a drop attack or cataplexy. If you're already sleeping, albeit in lighter stages of sleep, you'll then experience only the sleep paralysis. Hopefully you're not sleeping standing up, and the cataplexy will not occur, but sleep paralysis still will. If you're in a lighter stage of sleep, let's say theta, you could hallucinate. So people in a light stage of sleep, as well as people who are awake and alert, actively dream, and dreams in a wakeful state. are experienced as visual hallucinations. And then finally, the ED in the acronym stands for excessive daytime sleepiness. As you can imagine, if narcolepsy is occurring through the night, individuals may feel that they've gotten non-restorative sleep. That is, again, tertiary or late insomnia. And as a result, can complain that they're tired during the day. Right? Excessive daytime sleepiness. Quickly, I want to make a quick differentiation between fatigue, often referred to as lethargy, and excessive daytime sleepiness, often abbreviated EDS. Excessive daytime sleepiness incorporates fatigue and lethargy, but in addition, also is defined by individuals falling asleep when given the opportunity to. If you're lethargic, if you're fatigued, that is not the case. That's simply saying that you're tired. However, if you are given the opportunity, and this usually occurs during low stimulus situations, excessive daytime sleepiness will result in the patient nodding off. That's EDS. Now, again, if it happens once, there's nothing there. But if it's recurrent, EDS is going to be your diagnosis. And to the extent that EDS may be seen in the context of other findings, cataplexy, etc., narcolepsy may be the most likely diagnosis. The circadian rhythm sleep-wake disorders, otherwise circadian rhythm disorders, the C in Grinch. I want you to take a couple of seconds to stare at this picture as we are now at 10:30 and we're slowly but surely getting to lunchtime. Because Danish happens to be the acronym for the list of circadian rhythm sleep-wake disorders. The C in yellow, bottom left of your slide, reminds circadian rhythm disorders. And now the bottom right corner of your slide, Danish, will light up as we go through the different types of circadian rhythm disorders, starting with the delayed sleep phase type. So again, these are all subtypes of circadian rhythm disorders. Our circadian rhythm happens to be our internal clock that sets our sleep-wake cycle. For delayed sleep phase, you have the time you are asleep several hours later than desired. This is often experienced when people travel westward and go to an earlier time zone. Individuals who are likely to be afflicted with delayed sleep phase disorder, that is, again, the fact that sleep-wake times are several hours later, happen to be adolescents, the night owls, right? Delayed sleep phase disorder. That's compared to advanced, which is the direct opposite. Here, the time one is asleep is several hours earlier than desired. This is eastward travel. These are people who are usually elderly and are referred to as early birds. So we have advanced and delayed. Similar, albeit opposite. And here's your summary slide. Right? Again, advanced versus delayed. The sleep cycle is earlier versus later, eastward versus westward, elderly versus adolescents, the early bird versus the night owl. In either case, there are plenty of individuals, for example, those that are elderly, that have a delayed sleep phase, but not a disorder, because they do not feel as if it is impairing their function. Right. So I'm sorry, I meant to say advanced sleep phase, who are just early birds and they do not have a disorder. Similarly, we have individuals, usually adolescents, who are in a delayed sleep phase. They go to bed much later, especially when you compare their sleeping habits to adults and even older adults. These are usually adolescents. They are usually referred to as night owls, but they would not be diagnosed with having this particular type of circadian rhythm sleep-wake disorder if it doesn't impair functioning. It could be part of their normal routine.
So Dr. T, this is something that just physiologically is built into us, or is a result of something, that circadian rhythm?
Yeah, so I think the predisposer would be something built in. So we'd look at it as a biological circadian rhythm. However, I think the majority, the greater variance is explained by societal / cultural impact and what, for instance, adolescents must endure, resulting in they're having a delayed phase. Yeah, and I think it's much more biological, left side of your slide, for people who are elderly. Even though there's certainly psychosocial variables or factors that contribute, people who get older simply do not require as much sleep as they did when they were younger. So there, I'm going to say 60-40 biological, 40% psychosocial, but perhaps the opposite for the night owls. There, I usually see lifestyle playing the major role, that is psychosocial factors, and the biology playing a less significant role. Non-24. Here, there is abnormal synchronization between the 24-hour light-dark cycle, that is our usual day, and our own endogenous circadian rhythm, right? So our body, our internal clock, is simply not in sync with the day-night cycle. When the sun sets, or I should say when the sun rises and when the sun sets. For non-24, the cycle itself usually remains constant, however, right? But it's just out of sync. And that is different from the next example, which is the irregular type, in which there's just simply fragmented periods. So now these fragmented periods usually tend to occur between 2 a.m. and 6 a.m. And are commonly associated with neurocognitive disorders. But similar to non-24, there's just a dyssynchrony. Remember the first two, delayed versus advanced, there's asynchrony. That is, there's a phase shift. Everything is just shifted. This is different. In non-24 and irregular, there's dyssynchrony. And what differentiates irregular from non-24 is that in non-24, an individual's cycle, an individual's day-night habits remain constant, whereas in irregular, it does not. That's the main thing here. And then the final one is shift work. The SH finishing our acronym Danish is shift work. And I think this is pretty intuitive and obvious, and perhaps some of us have actually experienced this. A person who works outside of a quote unquote culturally sanctioned or normal schedule, which would be usually 8 a.m. to 6 p.m. Shift work type can also disrupt this synchrony. So those are the the 5 types of circadian rhythm disorders, remembered by the acronym Danish. Hypersomnolence disorder, exactly what it sounds like. It's very similar to insomnia disorder, but here the focus is on excessive sleep.
I'm sorry, my computer froze. I thought you guys were still on break, so now I'm on my phone. This is Kara. I apologize.
I'm sorry.
So I'm sorry.
No worries. Again, if as we're going through these, if you have any questions, please feel free to unmute. Very similar to insomnia disorder, there must be a pattern established, again, 3 times per week for at least 3 months, and of course, it must be clinically significant. And again, a summary slide here. Now bringing these two conditions together, the insomnia versus hypersomnia disorder. When we focus on sleep disorders in general, and here I'm going to use insomnia disorder as well as hypersomnolence disorder as examples. We always talk about biopsychosocial, and you've heard me actually discuss biopsychosocial factors as well as biopsychosocial treatment planning. However, in addition to that, clinicians must always remember that they could use the 3 Ps. That is a different rubric to look at risk factors and therefore come to an idea of what is causing or contributing to a particular behavior, such as insomnia and or hypersomnia. So looking at those factors, the 3 Ps that predispose, precipitate, and perpetuate. Predisposing factors of insomnia and hypersomnia disorder look to be anxiety, older age, female gender, no, I should say sex, so I apologize, and genetic predisposition to be a light sleeper, right? So if the clinician identifies these risk factors, what you've identified are potential predisposing factors to either insomnia and or hypersomnia, hypersomnolence disorder. Well, if Grinch focuses on the dysomnias, we have yet another acronym to identify the parasomnias. On your right, we shift from the North Pole to the South Pole. And in doing so, we are reminded that there is a remake of The Thing, so that 1950s sci-fi film is remade in the 1980s, and the producers decide to change the setting. That is, instead of setting the film in the North Pole, they set the film in the South Pole. And as the map on the right will reflect, there is a Rhone ice shelf due northwest of the Amundsen Scott Research Station. And that ice shelf provides the acronym Rhone to remember the parasomnias. The parasomnias can occur during non-REM and REM. We have already identified that the non-REM states occur during the first third of the sleep cycle, whereas REM sleep occurs predominantly in the last third. Individuals with a parasomnia during non-REM are often difficult to awaken. When awakened, they are often disoriented and they do not recall the details of what had been going on. On the other hand, individuals with a REM pathology are easily awakened. They are rapidly oriented and usually awake and alert. And that's a typo on the right side of your slide. They do not have amnesia. I'm sorry, I take it back. The typo is that they are switched. That is, for parasomnias and non-REM, detail is not recalled, whereas in REM pathology, it is recalled. And we're going to get to examples of that in a little bit, but excuse the typo. Again, non-REM, left side of your slide, detail not recalled. REM, right side of your slide, details are recalled. So delete the word amnesia there. REM sleep behavior disorder. This is a condition in which people will manifest very complex motor behaviors during REM sleep. And I think at first glance, this would appear to be counterintuitive, and it should be. Because remember, I told you that during REM sleep, during active dreaming, an individual will have sleep paralysis. They will have skeletal muscle atony. And that is nature's way to ensure that we do not act out our dreams. Unfortunately, that is not the rule for everybody. Some people, for whatever reason, maintain skeletal muscle function during REM sleep, during dreaming. And these people can actively act out their dreams. And when they do, and they're acting out their dreams results in clinically significant distress or impairment, the condition is called REM sleep behavior disorder, right? And people have reported getting up, walking downstairs, walking outside, ending up in the next town over, even driving their car while sleeping and while dreaming, right? So that's REM sleep behavior disorder. The O is a cheat. O stands for other. And other in this case means restless leg syndrome. So even though I cheated in putting that acronym together, ROAN, I think most people will identify restless leg syndrome or RLS. So it's not that big of a reach to have to remember this condition. Because we are so familiar with it, I think most of us also will remember that there's this urge to need to move your legs. And this urge is worse at night. It worsens or even begins during rest and activity. And when the individual does move their legs, that urge is relieved. And when that happens recurrently, restless leg syndrome is going to be the diagnosis, okay? And recurrent is defined, again, 3 times per week for 3 months. You could see I highlight it in blue. Every time recurrent is operationalized, it's defined as 3 times per week for at least 3 months. Non-rapid eye movement sleep arousal disorder, that's a mouthful. So basically, these are arousal disorders, right? And they occur during non-REM periods. 2 examples, and I think as soon as we talk about the examples, irrespective of how difficult it may be to remember the actual label of the illness, because it is a mouthful. These become fairly intuitive, right? Sleepwalking is exactly what it is. Individuals will actually get up and ambulate during sleep. And if you had to guess, you would guess that this would be non-REM, because the individual, by the mere fact that they are walking, are not in REM sleep. They do not have skeletal muscle atony. Sleepwalking is not a REM sleep behavior disorder. That they are 2 very different conditions. Sleepwalking is ambulation during non-REM. When you ambulate during REM, it's referred to as REM sleep behavior disorder. So it may look the same. So if you're a bed partner and you see your significant other up and around, fully asleep, you're not going to be able to tell whether they are sleepwalking or whether they have REM sleep behavior disorder, because it's going to look exactly the same. On the other hand, if they were to do such a thing during a polysomnography, during a sleep study, what the brain waves will show is that during sleepwalking, the individual is in a non-REM period, while during REM sleep behavior disorder, by definition, they will be during a REM period. So that's the way you're going to actually look to differentiate one from the other. The other thing we usually do in terms of differentiation and in terms of pairing that comes up in clinical practice is the condition of night terrors, otherwise referred to as night terror disorder, because people with night terrors appear like they're having pretty vivid nightmares. The difference, though, is that the sleep terrors, the night terrors, are during non-REM periods, whereas nightmares are bad dreams, which by definition would occur during REM. So there's another differentiation there. Nightmare disorder, like I just mentioned, are simply bad dreams. And if they are bad dreams, we know by definition, dreams must take place during REM periods. So nightmare disorder must be a REM pathology, and that would be true. Now, again, if you've ever had a nightmare before, irrespective of how distressing it may be, you are not mentally ill. You have this condition when the nightmares are repeated and are clinically significant. When they're clinically significant and they begin to impair your functioning, then it's a problem. Then nightmare disorder would be the most likely diagnosis. And again, I think that this slide really sums it up for us. Sleep terrors and sleepwalking occur during slow wave sleep, whereas nightmare disorder and REM sleep behavior disorder occur during REM. So, and I certainly highlighted the different letters, trying to match them best with the stage of sleep, slow wave versus REM. And then finally, to finish our list of ROAN is enuresis, which is considered to be an elimination disorder in the DSM-5. So it was pulled from the sleep-wake disorder chapter, but I want to include it here nonetheless. Quite frankly, if I didn't, it would ruin my acronym. But this is an individual who has repeated voiding, so urinating, when it is age inappropriate. So they are older than 5 years of age, and it is clinically significant. Right? So that is enuresis. And despite the fact that it is now in a new chapter of the DSM-5, we include it in this discussion as a sleep-wake disorder, repeated voiding during sleep, bedwetting, in someone who is older than 5 years of age. All right, so that will conclude our brief review. It is about 10 to 11 right now. Why don't we take a 10-minute break and come back at 11 o'clock and begin our film. Before we go to break, I want to ask anyone if they have any questions. Okay, with no questions, we'll take our break and we'll see everybody back at 11 for the start of Dr. Sleep. So it's about 1:30. Why don't we take a 5-minute break, stretch, and we'll see. We'll come back at 1:35 and begin our afternoon session then. All right, so we are at 1:35. For the next 90 or so minutes, what my goal is twofold. Number one, I'd like to just generate a discussion about the film so as to review and hopefully really cement the different conditions or disorders that we presented, that I introduced during the morning session today. And then, time permitting, maybe just a brief introduction about medications that have FDA approval for insomnia. So that'll be our twofold objective for this afternoon. So I think to address or to launch the initial part of the discussion, I'd ask for people to unmute and just let me know a particular character and a particular scene or behavior that struck them as interesting. No need to get to any pathology per se, but any character. Thoughts?
I thought they were all interesting in their own way. I'm exhausted thinking it through. I mean, from the theme on pedophilia, the theme of substance abuse, with Danny, was the whole thing just simply his withdrawal from alcohol and all the other substances you saw thrown in there? We saw him, you saw bong in the one thing, you saw cocaine, you heard him discuss that. So was there really no time lapse when they're saying this is 5 years, this is 11 years, and this is just all part of his hallucination? And then when you throw in the abuse of his dad, is this PTSD a flashback that really isn't taking 11 years? It's just one flashback. So good stuff, really interesting stuff, but so much to draw on every character. You could write a whole essay on each one of them.
I don't disagree. And let's start with the low-hanging fruit. Let's actually start with the scene in the beginning of this movie and the character, I believe unnamed, diagnosed with pedophilia, more specifically, pedophilic disorder, as per the APA as of 2013. So I know that this film was not about sexual deviancies, despite there being a character cast in the film with pedophilia. Nonetheless, it does give us an opportunity to briefly, tangentially, review pedophilia and understand the role of the paraphilias in regards to understanding human behavior. So, first and foremost, pedophilia or pedophilic disorder, by definition, is an adult having sexual contact with a prepubescent child. Right? That's the definition per the DSM. There's no issue of consent because of the victim's age. As many of us already know, this is not only a mental disorder, but it is also a crime. And that's been something that's been sometimes difficult to navigate, especially when teaching the topic. And then there are other variables to this, which I don't want to get into today, but are published in the DSM. And just one quick allusion, if the perpetrator is 2 years older, but in a long-standing relationship, then it is not pedophilia. And there's a lot of people who raise their eyebrows to that and say, whoa, wait a minute. But I will be quick to remind, just because it's not pedophilic disorder per the DSM, per the APA, that doesn't mean that the individual won't be prosecuted. There's another part of that, which is somewhat outside the scope of psychiatry, but certainly linked to or related to nonetheless. So that's pedophilia, which is the act itself. Pedophilic disorder would be the mental illness. Right now, this sexual deviancy is part of a rather long list of sexual deviancies. In the DSM, the APA has published 3 separate chapters covering the sexual disorders, one of which is titled the sexual deviancies, otherwise known as the paraphilias, right? Does anybody know the other two chapter names within the sexual disorder continuum? One is the sexual dysfunctions, erectile dysfunction, etc. And the other one is a condition which is only a single disorder within the entire chapter. It does have a chapter by itself, and that is gender dysphoria. That is when an individual experiences dysphoria due to a mismatch between their experienced gender and their sex assignment at birth, gender dysphoria. So those are the three chapters in the DSM covering the sexual disorders, one of which, that is a paraphilia, specifically pedophilic disorder, is captured in this movie. Now, one of the, actually, I'm going to ask a question. And again, if it's a little uncomfortable to unmute, I 100% get it. When, and I'm blanking on her name right now, when the character does what she does to the pedophile, anybody want to share their reaction? How did that make you feel as an audience member watching this movie?
I was with her until she started kissing him on the side of the head, and that made me very uncomfortable.
Yeah. Yeah. You know, and if for whatever reason the writer producer decided to edit that part out, I think a large consensus of individuals, of audience members watching this movie would have had no problem with what she did to him. And that's just the countertransference that results through film. And it's one that's paralleled in clinical practice, and one that is a significant barrier to psychiatrists in training when dealing with this particular population. That it's very difficult to teach empathy in situations like this. And when a person comes to you for help, but has committed a crime that you don't uphold or that you don't agree with, to be stated simply. Nonetheless, as a practicing healthcare provider, unconditional positive regard counts even when that client happens to be a pedophile, if that is the actual chief complaint for which they are seeking help. And I think that's brought about in this movie, because I have to agree with you. Matter of fact, her kissing him didn't even bother me. I felt that it was her sense of power over him, which I think puts an exclamation point on what she did to him.
So I happened to, I had looked at it, this was the second time I saw it last week too. So I had my own thoughts last week. And then there were things I looked at this week, but I took it as if she was taking her own control back. That's how I looked at it. So it didn't kind of weird me out, because I thought that's what she was doing. Now, at the same time, do I think she should be killing anybody? No, or marking them up. But I did. That's how I took it, as, you know, I'm taking my control back.
Yeah, and actually, I think you're right on. And the reason why is because, and this is cheating a little bit, but that happens to be a fairly prominent Stephen King theme. So to see this, and if somebody were to try to, at this point, which is perfectly reasonable and okay, to make a counterpoint to that, they would really have to go up against not only your opinion, but the opinion of Stephen King, because he has that as a fairly constant theme in a lot of his movies. And that includes one that I'm thinking of here is Gerald's Game, right? I mean, Gerald's Game is all about the main character taking her life back and regaining control, and taking it back from the men in her life that have been nothing short of predators, right? So very common Stephen King theme. So it makes a ton of sense that it's in this movie as well, and in that character as well. You know.
Can I go back to the first question that you had about the characters? So I focused in on Danny, and of course I love The Shining. So I had to separate The Shining from this. I felt like I had to separate the two movies. But when Janice mentioned the bombs, the people were human bombs. That's how I was looking at it,
Yeah.
that, you know, that these people, the smoke was coming out of these people and they were inhaling whatever they were in, the substance. So, you know, and I, my whole thing was, I wasn't really sure if it was sleep or if it was hallucination by him coming down from whatever he was coming down from. You know, so that, you know, and at the end, my thought was he took back his life in a sense. It was all over. The substance abuse has ended. I don't know. That's a,
No, this is, you give us a lot to work with here. Let's peel these layers back. First and foremost, I do like the idea that this movie provides not one, but several metaphors with regard to steam and the use of substances. We can't miss this one. And I've taken a lot of screenshots of the different times people's victims' steam have been inhaled, right? So I think that's first and foremost. Having said that, you mentioned bong. What else might be in a differential diagnosis with regard to the type of substance that this serves as a metaphor for?
I was thinking LSD.
Could be
That's what I was
LSD.
thinking. Yeah.
Just that. No, let me see if I can actually hold on one second here. I'm going to see if I can bring up a picture or two that I captured. I wasn't as nearly as adept in doing this as I thought I might have been and perhaps should have been. But here, maybe this one. Let's share my screen. Right. I mean, and then of course, a second after this, you'd actually see Rose the Hat, others in the cult surrounding them. There they are, you know, another scene, actually breathing in the steam. Look at this guy in the back. Well, he's having fun. All right, so with that, I'll stop sharing. So what those scenes, and there's multiple, but what those scenes I think demonstrate is inhalant use disorder. I mean, the one thing about inhalants, and there's 4 subclasses, is that for each, there is a vapor that is created that the individual uses via the intranasal or the oral route. That is, they take in the vapor, AKA steam. The other thing I thought was interesting is that, and I don't have the specific substance, although I think it might be a nitrite, which is one of those substances that that are an example of inhalant. Like again, aerosols, nitrites are the part of the subcategories. A street name for nitrites happens to be grease, and I thought it was interesting that Rose the Hat in Finding Danny and discovering Danny says, I can see the grease all over you, which I thought was really interesting choice of words. Now, again, I don't think the writer-director went to Urban Dictionary and found that the word grease is street slang for nitrites. I doubt it very much, but you know what, it works. And you know, we have to wonder whether or not the plot of this particular movie just so happens to be the experience of someone who is using or is intoxicated from nitrites in particular, perhaps just inhalants in general. So if someone were to present to you intoxicated from inhalants, what would they look like?
What was the question? You cut out on mine.
If someone were to present with acute inhalant intoxication, what are some signs and symptoms that you would identify to be able to make a correct diagnosis?
So you look at if they can walk, if they're talking, if they're slurring their words, you know, just like what police do. If you can do simple things like count backwards from 100, you know, some simple cognitive tests.
Cognitive, even motor tasks. Yep, everything you named is correct. Actually taken right from the list, right from the diagnostic criteria set. And if you look at the criteria set for inhalant, specifically inhalant intoxication, it matches that of alcohol intoxication. So we've all seen people who are drunk, for better or for worse. And in looking at anybody who might be drunk, you really would not be able to clinically distinguish them from someone who is high due to inhalants. Now, there are a couple of things you can look into to help differentiate, especially as is my life, it might appear on an exam. Number one is that the individual with inhalants are usually euphoric. So euphoria is actually an intended effect. It's a big reason why individuals use or abuse inhalants, the euphoria. While alcohol, as we all know, is disinhibiting, and people can become irritable. They can become loud. They are not euphoric. Alcohol is a CNS depressant. The chronic use of alcohol can induce depression. So it's the opposite of euphoria. So if you see the euphoric, the grandiosity, much more likely in someone who is quote unquote acting drunk to be due to inhalant use. The other thing you have to remember here with regard to inhalants is that individuals who use any of the four subtypes, nitrites, aerosols, solvents, or gases, can have neurological sequelae. Okay, they could have seizures, they could have permanent neurological damage, they can have tremor, and that's with a single use. So you can actually see those neurologic signs during intoxication. That is not the case for alcohol. Alcohol does have a neurologic syndrome attached to it. It's called the Wernicke's Korsakov syndrome, or the WK syndrome. But what Wernicke's Korsakov is it's neurological damage brought about by years of alcohol use, not just a single use and not during intoxication. So that's quite different. But those are the two main differences. The neurological sequelae's onset clinically distinguishes alcohol from inhalants, and so does euphoria versus depression. Euphoria for inhalants, depression for alcohol.
Quick question. I'm actually looking at the DSM now, and euphoria is at the bottom, but it's a lot of dizziness, slurred speech, depressive, retardation. But also what strikes me is I know that when you go into diabetic shock, you can look as though you're intoxicated.
Yeah, any episodes of hypoglycemia. So somebody takes their diabetic meds and then doesn't eat breakfast or doesn't eat lunch, and their blood sugar goes low. Yes, they can become combative. They can slur their speech. They can have difficulty walking. Yes, they absolutely look drunk. Yep, it's absolutely true. So, and again, this shouldn't surprise anyone. That is, the intoxication syndromes, such as that from alcohol and inhalants, can also mimic medical conditions. This is something, of course, we work very closely with our emergency medicine peers, that when somebody comes in and they look like, quote unquote, they are high or they are drunk, be very careful to stigmatize, because there could be not only a medical condition, but as such as the example of hypoglycemia, a medical condition that can lead to imminent demise and death. So always maintain that high clinical index of suspicion. And again, I don't have to tell ED personnel that they're given the glucose already. Certainly the folks that I work with, I have very little, if any, concern with regard to stigmatization resulting in their missing a potential life-threatening illness.
I'd like to say one thing. In the news last year, a young man was naked in the garage, and his grandmother was in the house, and the police shot him. And I'm like, if they didn't know that was a mental illness, that was such negligence. Someone's running around naked and acting crazy. It's meth or LSD, or it could be anything. But he didn't deserve to be shot and killed. So I think that's why they're talking about with police getting more social workers, mental health people involved, Because I'm thinking if I was there, I'd say, dude, don't shoot him. Maybe try to handcuff him or do something, or, I don't know if they give him a shot to calm him down, whatever, but not shoot him and kill him. So just
Completely agree with you. I think I know the case you're referring to. And if I recall correctly, the man was not even intoxicated. If I recall, if this is the same case, drugs were not involved. This was an acute episode, an exacerbation.
Yeah, it was
of
mental. It
schizophrenia.
was mental health. Yeah, it was a psychosis. It wasn't even intoxication or drug use, which makes it even worse.
Yes, it does. All human
Especially
lives are
because they
equal,
could have
but
talked to the
my
grandmother,
personal opinion, yeah. I totally get it. We do work closely with our local PD. We, meaning University Behavioral Health Care, which is an affiliate, another branch of Rutgers University. So we are very sensitive to that and the role that we as providers play in educating our local PD. Absolutely. And, to the extent, and we're going to see this certainly even in greater context because of COVID, but to the extent that these events are going to continue to happen, that is people with worsening mental health issues, we should start considering, like you pointed out, having our first responders have syringes of benzodiazepine, haloperidol, these sedatives, just the same way they have Narcan. If we're thinking Narcan because of the opioid crisis and epidemic, well, there's an epidemic in mental health too.
Mhm.
And these events could be mitigated safely if our local first responders also carried sedatives in addition to the Narcan. Just a thought.
I have to tell you, I don't really know too much about policing, but I'm surprised they don't, because if you go into an ER and you're acting crazy, they think, just hit them with Ativan, whatever milligrams of Ativan. And I worked in a mental health lockdown facility at Jersey Shore, and they had to do that to people. So, I mean, if police is this far from somebody and some policeman can just shoot them with something. Actually, is something that they overuse sometimes, police, to calm people down?
Not that I'm aware of.
I think there's some drug. I can't think of what
Really?
it is. Yeah,
The
maybe it'll
police
come
carry?
to me. Yeah, I'm trying to think what it is that I've heard in the news that they've used and overdosed some people with. I'll try to think of it. I don't think it's something everybody carries.
Yeah, let me know, because I'm blanking on that right now.
Okay.
I do want to get back to your point too about Danny now as well. We identify his being a recovering alcoholic and perhaps even addict with regard to other drugs that are mentioned in the same context. And there's that role of steam as well. Steam is internally his shining, right? It's his gift that this particular cult obviously is trying to harvest. So there's a link between Danny's gift and I think his alcohol use disorder. Remember, he uses alcohol after the events of the Overlook way back in 1980.
Mm-hmm.
He uses alcohol to suppress the drive of the shining, that is to suppress his shining, to suppress his steam. And then when he's recovering and he's going to AA and he is sober, he has the use of his shining again. So there's a nice inverse relationship between the two. And as such, I'm wondering if Danny's shining, if his steam is a metaphor for his memories and his repressed memories in particular, because once he stops using, his shine comes back. And we know that in clinical practice, individuals suffering from conditions like post-traumatic stress disorder may self-medicate with alcohol to suppress those traumatic memories. So that's a consideration here in terms of what ails Danny Torrance as an adult, although I think it is low-hanging fruit. I think most of us, after having seen The Shining in 1980, I think it may have premiered in around October. I think by November, we already guessed way back in 1980 that the sequel would likely identify Danny as struggling with PTSD, because what happened to him not only in the overlook, but even before physical abuse at the hands of his father, certainly provided that trauma risk.
I have a quick question.
Yep.
Really, it's about the movie. Who was in the bathtub at the end? I know that person was, who was that? That Abba ended up going into the bathroom and that same figure was in the tub. Who was that?
I'm not sure if I know.
Okay, good. I feel better. Thanks.
Hey, wasn't she the old lady from The Shining in the tub? Like,
It
wasn't
was, yeah, she was.
right?
Uh-huh.
She was one of
I-
those
she
people
has a
in the
name.
house.
Like Mrs. something or other.
But she was a big terror of Danny's when he was a little boy.
Mhm.
Okay, and I didn't see The Shining because every time I started, I really get scared. So Jack Nicholson just does it. So thanks.
So again, I don't really know her role per se, even dating back to 1980 in the original. Certainly, she is the quote unquote kind old lady that lures that lures Danny as a child into room 237, only to attack him, trying to cannibalize him, grabbing his throat. He then shows up with those injuries to Wendy, who then runs to Jack and accuses Jack of putting his hands on Danny. Upon the accusation, Jack then goes and investigates room 237 and meets the same person, albeit seducing him. First kind, attractive, seducing, and then turning into that quote unquote witch, right? So in each, we're dealing with the Hansel and Gretel motif in each. Right?
And I also think because it's a movie, they always want to make room for, the Sleep Doctor Part 2. So you can start a whole other movie just based on the little girl going in the bathroom with the old lady.
Mm.
So.
Yeah, I was gonna. That's a great point. I was actually going to address that, and something that Janice said as well, with regard to there's so much to unpack here that I could see Netflix just taking one of these on per season. I mean, you could pick your top 5, and we've got 5 years of this then to unwrap over a Netflix series. I could definitely see them doing this. Hopefully, when they do it, they'll consult us because we're already doing their job for them in making these discussion points. At least in as much as it's related to psychiatry.
There were some, can I just mention, there were some really good, I've worked, I'm an LCADC as well as an LCSW, so I've worked in addiction. And I love when, I'm trying to think who said it. They said the mind is a blackboard and the alcohol or whatever drugs is the eraser. I mean, that's great. That's really a good, analogy to use for people. And the other one, I think Tony said it, the world is one big hospice with fresh air. Like we're all dying.
Yeah.
There are so many good quotes in this, that you can, make a whole course out of.
And I think references to Jane, to when the one guy says, wherever you go, there you are. I mean, that's so AA. That's so.
That's the name of a book.
Right. It just is like, and also I loved the fact that the little boy, well, I hated, that was my least favorite scene in the whole movie. I had to sort of block my eyes from that. But when you see him walking by the cornfield, and I'm thinking of Field of Dreams, that reference to that movie, which just in my brain, that's what I saw when I saw the little boy walking in the cornfield. So there were so many things. I mean, I think we could have stopped the movie every 15 minutes and talked about those kinds of things that we saw or perceived.
I completely agree with you. One of the screenshots that I was able to take was the little boy walking across those cornfields, especially when it was identified that he was from Iowa.
Mhm.
Right. I mean, there's not that many films shot in Iowa, but Doctor Sleep and Field of Dreams just so happened to be 2 of them. Completely, again, I completely agree. And the comment about the quote pertaining to hospice, I think is something we should spend just a couple of minutes on, because not only does it kind of bring out this whole idea that we're all dying, the world is one big hospice, but then it links directly to existential theory. right? And Dr. Sleep certainly at this juncture becomes an exercise in existentialism. So if we all understand our ultimate fate, how do we make sense of it all? What gets us up in the morning when we know the inevitable? And that's what Danny Torrance himself has to face. He has to actually accept the shining as a gift. And how does he do that? He actually applies it in the service of others. And that is a huge addictions piece right there, in the service of others. So I think it all comes full circle. I mean, we have the hospice quote. We have it really identified as the central idea of existentialism. And with existential theory, individuals who are struggling with regard to, what is this all about, really find the answer in their own personal gift. And more times than not, it's in the service of others, which, by the way, the character of Danny Torrance nails. He takes this curse, this thing that literally has haunted him. He stops drinking and he embraces it. And it becomes a gift only when it is in the service of others. And he makes others comfortable, therefore setting his own existential path. Any other observations from the film? Other characters you wanted to briefly touch on before I get into some medications that have been FDA approved for use for the sleep disorders?
Can I just throw in one more thing? I loved the conversation between Rose when they were talking about having identified Abra, and my computer blanked out on a couple of the words, but it sounded like he was saying to Rose, should we turn her or should we eat her? And there's a conversation about, well, she'll go to psychiatrists, if she manifests this stuff outwardly, and they'll put her on Paxil. Did anybody catch that? And then they're saying like, no, that's not a good thing. So I thought, boy, Stephen King is just honing in on some of those bigger issues of, okay, we'll medicate it away, which happens in life, happens today in our world. So that stuck out to me too. Although, as I said, I didn't hear the entire sentence, but I think that was the inference.
Yeah, again, that with regard to Abra is juxtaposed to Danny, who in fact does self-medicate, right? And which is the worst of the two evils. Now, again, believe me, I prescribe a lot of medication to a lot of people, so I don't mean to come off as sounding that I'm against medications. Far from it. But that said, the comment with regard to Paxil I take is when a clinician prescribes a medication and then ignores the other aspects of a comprehensive biopsychosocial treatment plan.
Right.
We've got a biological on board, and perhaps there's other biological things we should consider as well, but we have one, it checks that proverbial box. What about the psychosocial elements to that treatment plan? And to ignore that, largely due to a 15 or 20-minute med check, is something that I think is indefensible. And that's how I take this particular that particular quote. Anything else? All right. Well, I've got plenty of notes, but again, I don't want to go off on that many tangents. I certainly wanted to make sure we got the medication discussion in. So with that, let me go ahead and get to the slide set that will be towards the end of your presentation. I have it as slide number 79. Hopefully it's the same, or at least in the ballpark. Give everyone a second to catch up, and I will share my screen. So right on cue, again, the treatment for insomnia, the treatment for the sleep-wake disorders is a biopsychosocial treatment plan. And what you'll recognize at the right side of your slide is the narrator from David Fincher's Fight Club. Now, I'll make reference to this film. You do not need to have watched this movie. We certainly didn't watch it today to understand the different things that I'll review today. However, I do want to reference for those who either have seen this film or know about this film. And certainly, I think following this particular discussion or this part of the discussion, if you happen to watch Fight Club this week over the weekend, it will cement the different points I make for the next half an hour to 45 minutes. So what you see here is a list of medications used to treat insomnia. The acronym is MARLAS, M-A-R-L-A-S, and that's relevant because one of the main characters in Fincher's film is named Marla. So melatonin, Ambien, Rosarum, Lunesta, Amantilla, which is valerian root, and then Sonata, right? Those are the 5 different medications and substances that we'll review over the next 45 minutes or so. The bullet will point out, identifies those medications that have FDA warnings. So every other medication, the way these meds are listed, including Ambien, Lunesta, Sonata, every other medication beginning with Ambien has an FDA warning. When we go through the medications, we'll discuss what that FDA warning is. Some background. We know in the film that the main character, the protagonist, sees a doctor and he asks his doctor for barbiturates. He's suffering from chronic insomnia and he asks for barbs. The physician says no, and instead refers him to psychosocial rehabilitation, specifically to self-help groups. Makes a comment about learn what real suffering is about. He does, and then identifies that it works, quote unquote, babies don't sleep this well. It is interesting that in the dialogue with the ER physician, he says no to the barbiturates, and if there's going to be anything prescribed or recommended, it was valerian root. But I think that Fincher, this is the writer-director, actually does have that physician prescribe something nonetheless. And I think that scene that he does prescribe something is cut out. But there's enough evidence in this film to suggest and support that our protagonist, our narrator, does leave that hospital with a prescription. And when you watch Fight Club and you watch for that information and you actively look for it, I don't know if it's that difficult to find, right? So again, just a prompt, a tease to watch this film over the weekend. When we look at all the medications in that list, MARLAS, all of those medications, here are the common characteristics. All these medications are metabolized in the liver, so we have to be sensitive and careful in prescribing any of MARLAS in someone who has liver damage or does not have normal liver function. As you would guess, all these medications can lend to excessive sedation. All of them can give you a headache. They act through the central nervous system, they act in the brain, and as such, can cause headache, dizziness, and lightheadedness. So again, I don't know if that's a stretch. I think, relatively speaking, that's something that everyone here would expect. The first medication is melatonin. And if I were to prescribe a medication, when I prescribe a medication, this is usually the first medication I reach for. Melatonin is a naturally occurring hormone that is produced in the central nervous system. It is produced by your brain normally. It has been synthesized about 20 years ago. So we obviously can get it in pill form, and it is right now over the counter. Exogenous melatonin, that is melatonin pills, have been used in a variety of clinical settings. And the one we actually see them most frequently used is in that group of disorders that we reviewed earlier called the circadian rhythm sleep-wake disorders. Now, in the film, Edward Norton's character, our protagonist, has several scenes in which he is on a flight and often goes from the east to west to back to the East Coast again. So I think that it's very reasonable to assume that his insomnia, if not due to, if not the result from, is at least influenced by a circadian rhythm sleep-wake disorder. I mentioned before that this is a naturally occurring neurohormone. It's produced in our pineal gland, which is a gland that is pretty much in the apple core of our brain. When you take it as a pill, it will reach a peak concentration about 60 minutes. So when you want to fall asleep for 11 o'clock, you would take the melatonin closer to 10 to get it to peak concentration so that you can rest at your bedtime. No real adverse effects noted in clinical trials, but when you provide higher than recommended doses, specifically over 8 milligrams a day, individuals can actually feel dysphoric. So certainly folks with history of depression, prescribing melatonin, in prescribing melatonin, you do have to be somewhat careful. So this is actually listed on the melatonin website. This is listed as part of the medication information, but I can tell you, and I've spoken with pharmacists and pharmacies in our hospital, and even with folks with autoimmune disorders, so thyroid illness, rheumatoid arthritis, lupus, melatonin is still very often prescribed. So we know the molecule itself does play a role in immune function, but it does not look like that is clinically relevant, that is clinically significant in prescribing melatonin for insomnia. Any questions about melatonin?
So are you saying that that it's not, if you want to avoid autoimmune disorders, you should avoid melatonin?
No, what the package insert says is that
other?
you've got to be very careful prescribing this medication in people or to people with known autoimmune disorders. But other than that warning, I've never seen anything adverse happen, either in the medical literature or certainly in my experience. So despite the warning in the package insert, this medication nonetheless is readily prescribed to people with such conditions like lupus, rheumatoid arthritis, etc.
But there's no correlation between taking melatonin and having an autoimmune disease.
None at all, no.
No cause and effect. Okay.
No, absolutely not, no. Nope. Now, one of the reasons why I like starting with melatonin, and it just happens that it is the first initial in the acronym, which gives it a perfect place, is that if it doesn't work and you're having to prescribe something else, you can give your patient the option. Either they can have something added to the melatonin or replace it. There's little to no harm in adding to the medication because the rest of the medications that are FDA approved work by a mechanism completely separate from melatonin. So dual therapy is something that is definitely on the table, especially since you have the melatonin already on board. So that is an option that presents itself just because you happen to choose melatonin as your first line agent. So for example, if the melatonin at the optimized dose isn't working, you can either replace it with Ambien, or you can add Ambien to the melatonin and have the person take 2 medications at bedtime. Ambien is a sedative, and it is classified as a non-benzodiazepine sedative. Benzodiazepine here, abbreviated BZ. It's been introduced and it's been used since the early 1990s. it is a strong sedative, but it acts less as an anxiolytic, right? So good for sedation, not so good for anxiety. The mechanism of action here I mentioned before is different than that of Ambien, different than that of melatonin. Melatonin is a naturally occurring neurohormone, whereas Ambien binds to the benzodiazepine receptor, I should say the receptor complex. And as such, increases a neurotransmitter called GABA, G-A-B-A, which is a sedating inhibitory neurotransmitter. It is a sedating chemical messenger in the brain, which is why you get drowsy when you take Ambien. Despite it binding to the benzodiazepine receptor complex, tolerance does not appear to develop towards the sedating effect. Now, the added side effect here is that Ambien could lend to stomach upset. So in addition to those other headache, dizziness, etc., that were previously mentioned that go and represent all of these agents, an additional side effect for Ambien in particular is GI upset. The R in the acronym stands for Rameltian, that's Rosarum. This is very similar to melatonin. That is, it isn't melatonin, but it binds to the same receptor that melatonin binds to. Similar to melatonin, you get a peak plasma level at about an hour. Right? And the other thing about this is that, well, two quick things. Number one, similar to the Ambien, this also can upset your stomach. And it's metabolized by this specific enzyme in the liver called 1A2. And I'll get to the meaning behind that and why that information is useful. Remember, all these medications are metabolized in the liver. This one is metabolized through a specific liver process. That is a protein that is named 1A2 that is found in the liver. Lunesta. Lunesta, for all intents and purposes, increases sedation, induces sleep through largely unknown mechanisms. Again, it's more sedating than it is anxiolytic. The absorption can actually be increased with a high-fat meal, right? So, for instance, a person could be taking Lunesta for days on end, and then one day they atypically eat a high-fat meal, and they could become oversedated as a result because of the increased absorption that they had not been accustomed to. Similar to the Rosarum, Lunesta is also metabolized by 1A2. And the other thing about Lunesta, highlighted in yellow, that final bullet, is that people can have very vivid and abnormal dreams and act on them, leading to accidental injury. That's Lunesta. Sonata is another medication that acts on the GABA. Remember, that's the neurotransmitter that's largely inhibitory in the central nervous system. Benzodiazepine receptor complex. It has a shorter half-life than zolpidem. Again, it's a very strong sedative, not so much anxiolytic. It also acts on 1A2. And again, we see side effects, including GI upset. All right, so that's a very quick review. Now, I could definitely fold this into more of the plot of Fight Club. But before I do that, let me unshare, stop sharing my screen. So what questions do we have with regard to the biological part of the biopsychosocial treatment plan. Any questions about the medications? As far as the acronym goes, you probably noticed I left off the Valerian route because while people do use it to initiate sleep, it has not been FDA approved. So it didn't actually, or wasn't actually contained in my slide set.
Isn't trazodone prescribed a lot for sleep?
Definitely is, but it's not FDA approved. So the only the medications that are FDA approved that I go through there. So let's talk a little bit about trazodone. That's Deseril, right? Deseril is an FDA approved antidepressant, right? But in clinical studies, it was shown that individuals have to titrate up to 400 milligrams to get the antidepressant effect. At milligram dosages that are lower than 400 milligrams, the antidepressant effect is not clinically significant. The problem with that is that it is very sedating, and this medication is very poorly tolerated. That is, people tell their prescriber that the medication must be stopped, usually far before they get to 400 milligrams. And that's been such a frequent occurrence that a lot of prescribers simply skip over it with regard to treating depression. They don't even consider it because of how often this medication is poorly tolerated. Right? Nonetheless, because of that, prescribers do use this medication for sleep initiation. So for early insomnia, remember difficulty falling asleep, trazodone is often prescribed despite the fact that the Food and Drug Administration has not approved it for use.
That's what I was going to say, is Dorinda. Trazodone, I work with a psychiatrist, it's often prescribed. But then we have a lot of complaints about Ambien that it's not working, the side effects. So I get a lot of complaints from the patients.
Yep.
What would you say a good medication? I know it's individualized. What would you say a good medication would be for insomnia?
So I always start out with melatonin. And so remember, my practice is hospital-based. So I see only people admitted to Robert Wood Johnson University Hospital, and I see them during acute medical conditions, right? Otherwise, they wouldn't be admitted. And often when I see them, they complain of difficulty sleeping. And if anybody's ever spent any time in the hospital, you know that's a common complaint. Once you do snooze, you have somebody barging into your room, waking you up, right? So insomnia is very, very common in the hospital. Nonetheless, we have to address it. I want to get to some of the psychosocial interventions in a second, but they're usually not that effective in a hospital setting. We usually have to resort to medications because the patients don't want to say, oh, you're going to get an effect in 2 weeks when they're going to be discharged in 2 days. That doesn't, that's not going to serve anybody any good. So they want a medication. We prescribe a medication. Ambien is the first medication we prescribe. We titrate it rather quickly to its maximum dose of 10. If it works, that's terrific. We could have another discussion on whether it should be continued as an outpatient, usually not. But if it doesn't work, I like to keep it on, and I like to add trazodone as my second agent. I do have a discussion with my patients that this medication is very effective despite it not having FDA approval. And as long as my patient understands that and consents, that's perfectly fine. We are allowed to suggest, recommend, and even prescribe medications off-label, that is, without FDA approval, upon full informed consent. Now, for women, I do one thing. For women, I give them trazodone, depending on how old they are, depending on how many comorbid medical conditions they have, and depending on the severity of their insomnia and their weight, I will choose a starting dose. So let's just play with a round number, let's say 50. What I will then do is prescribe the 50 milligrams at bedtime, but then I prescribe 50 milligrams every 30 minutes until they fall asleep. Now, we all know that 400 milligrams is the usual dose we have to achieve to treat depression. So the fact of the matter is that they can get 8 doses of 50 even before they get to the 400. So it's an easy way to titrate up to ensure that my patient is going to definitely get a night's sleep, whether it's with the initial dose or whether it's with the 4 subsequent doses that follow that initial dose. I'm getting them to sleep that night. And when I come in the next morning and round on my patients, I'll know the milligram dosage they required, and I'll just reorder that as a single one-time dose. Now, men are trickier. Anybody know why? And be nice.
Okay.
Okay, thank you.
All right.
Thoughts? There's a side effect of trazodone that you have to be careful in prescribing it to males. What is priapism?
Sustained erection?
Yeah. So it's rare. It's a rare side effect, but it is a side effect nonetheless. And it is certainly a side effect that gives me pause with regard to implementing the same type of regimen in males. So in males, I'll give them the one-time dose, and I'll give them 1 dose as needed to follow up if the insomnia persists, but that's it. I'm not dose escalating to 400 milligrams the way I would for a woman in the hospital. So trazodone is usually my second-line agent for males, but I use it much more conservatively because we've had at least 2 transfers from an outside hospital to our surgical team for trazodone-induced priapism. And they have to actually undergo a vascular shunt procedure to undo the prolonged erection. And in both cases that we were partnering with the surgical team to address that, the vascular shunt failed and the genitalia became gangrenous and fell off, right? So I'm a little hesitant to overdose the trazodone and provide the same regimen as I do for females, right?
So Dr. T, you said you use in females the Ambien plus the trazodone with the titration. So for males, are you also using the Ambien plus the 1 dose and possibly 1 more? Okay.
Exactly right.
Would you say that you said women and age, what is the age factor? Trazodone is better for older women than younger, or?
Oh, no. It's just that older individuals are more susceptible to those side effects. Remember, the sedation effect of trazodone is a side effect of the antidepressant. So people who are older are just more susceptible and sensitive to medication side effects in general. Therefore, a particular milligram dose is going to be more poorly tolerated by someone who's 77 versus someone who is 27. So as an example, if anyone here was depressed and came to see me and I prescribed trazodone and I was titrating you up to 400, at some point you're probably going to complain, hey, Dr. T, this is knocking me out. I mean, is there anything else you can give me? The dose we achieved, let's say it's 300, let's say we almost got there, is going to be significantly less tolerated in someone who is 77. I mean,
Yeah,
when
so
I give
trazodone for sleep is like 50 milligrams may work fine for an older woman for sleep, not depression. So I was just wondering if, what would you give somebody who's like in their 60s for sleep as opposed to a younger person in their 20s?
Looks like his screen froze.
Oh,
Yeah.
he just texted. He's rebooting now. I
Yeah,
guess.
that's what happened. That's what happened to me earlier.
Oh, yeah, I'm
So
wondering what is going on.
I was wondering the same thing.
He didn't like my question.
I thought my sound cut out, so.
Like, shut up already. Where I work, the doctors are very hesitant about Ambien. You know, more than 2 or 3 nights. That's why I'm surprised that he's like so pro Ambien and throwing some trazodone.
Also, where I work at too, the psychiatrist just called me. They are also very skeptical about Ambien. I have worked with one APN and one psychiatrist. So
Yeah, like
that's
their go-to where I work is trazodone first, melatonin, of course, and they even tell them to take Benadryl if it's just an acute, can't sleep.
I never heard the
Well, Benadryl is the same thing that's in NyQuil, hydro something,
Yes.
something. It's the same chemical that's in a lot of over-the-counter sleep aids.
A Benadryl, though, could do the opposite for people. It could also
Yeah,
make you
get them
very
hyper.
hyper. Because
Mhm.
my daughter's on the autism spectrum, so she used to take Benadryl when she was younger, and that would put her to, help her sleep. But then as she got older, she was flying on it. So we had to take her off that. And then went to melatonin, but
Yeah, I think they were using Benadryl for homemade meth. And that's why they put it like behind locks counters with the
Wow.
with the key
It's
on it.
also possible in the hospital with the Ambien is because I know when I worked inpatient, there were a lot of addicts and it can be habit forming.
Yeah, you could
And-
never give Ambien to an addict.
No, so they went to trazodone first also.
I know a lot of people coming out of residential treatment come out with a prescription for trazodone,
Right.
but they still get like high from it, even though it's sedation high. It's better than no high. So it becomes something still desirable. And I have people saying somebody stole my trazodone, in the sober house and stuff, so we're talking about addiction and what you would prescribe for somebody with, an addiction background.
Yeah, no, absolutely. So I
And-
apologize.
And
I was
sleep
just
me-
kicked off.
and sleep medications.
Right, just for sedation, yeah. Where I would be in this algorithm is always Ambien first and always trazodone second. If trazodone fails, and I'm looking for a third agent, that one is going to be a coin toss. That has a lot to do with other factors involved, picking one from the other. For example, if I am dealing and I am treating a recovering alcoholic or addict, I might go to another off-label medication that I know will not be habit-forming, like an antipsychotic, like something very sedating, like quetiapine, which is Seroquel, or olanzapine, which is Zyprexa. Again, another off-label med, but either of which, these antipsychotics, very, very sedating. They're not habit-forming, and might be my number 3 in that special populations. That's one example. And I don't mind coming up with 3. If a patient needs to fall asleep in the hospital, they need to fall asleep in the hospital. I don't anticipate continuing any of them upon discharge. So whatever we do and whatever we focus on is actually just that. It's focused on getting the individual a good night's sleep while in the hospital and get stopped the day of hospital discharge. Before we get to some psychosocial components of this, what else can I address with regard to medications used to treat insomnia?
You
All
said
right.
earlier you would not prescribe like Ambien unless you're talking about when they're going off of it, correct?
Correct.
So it's not something you would see someone taking for years. It would be, okay,
Correct.
we're going to give it to you. And at the end of 30 days, if they're like, this stuff really works great, doc, what do I do? Can I keep taking it? What do you tell them? No, let's go to trazodone, or let's go to,
All right, well,
Seroquel or something.
let me answer that then. Right. And, again, this is a conversation that I don't have because I am hospital based, but let's pretend as was my former life, I had outpatient hours too.
That's
This
what I
is where
do.
this question comes up all the time. And quite frankly, this conversation takes place, whether it's Ambien or something that is similarly habit forming or not.
Any
So
any
this takes
benzo.
place for, right. And now melatonin, I might let you get away with. That depends how I feel, to be honest with you, because it is naturally occurring. But
And it's over
trazodone is
the
included in this
counter.
conversation.
There's gummy melatonins.
They are. Yep. There are. So here's the bottom line with this. First, we have to start with reviewing proper sleep hygiene. And there's two things I want to get across here. One is a general statement, which I'm going to share with you in just a second. But then the other are the specifics to what we need to review and you need to incorporate as your lifestyle. Okay. So first things first, what are those things, if anybody had to guess, will we now begin to discuss in the context of what is usually referred to as proper sleep hygiene?
I would think use of caffeine, exercise right before bed, a bedroom that's too hot, uncomfortable beds, like physically uncomfortable pillows and beds. And then also some regularity, I would say, with when you wake up, when you go to sleep. Those come to my mind.
All are exactly correct. We are going to talk about limiting, if not eliminating, the use of caffeine. We certainly are going to avoid caffeine in the late afternoon and evening, and that includes decaffeinated beverages, decaffeinated coffee. It is time to take an inventory of your bedroom or where you sleep. And I want you to write this down. I want you to actually take an inventory, and at your next clinic visit, I want you to show me what you wrote down. I want to get a feel of the way things look, the way things smell, the way things feel, comfortable, uncomfortable, hot, cold, etc. Take an inventory. I want you to have a routine in winding down to sleep. I want you to make it a ritual. And I want you to make it a ritual that you look forward to, right? So all of those things are in play. Proper exercise, right? What can somebody tell me the definition of the word proper when a physician says proper exercise?
No.
Proper exercise. Everybody sitting down?
Yeah.
5 days a week, 20 minutes of exercise with regard to cardiovascular. All right. So aerobic, 20 minutes, maybe 30, but I'll give you 20 minutes, 5 days a week. If you do not do that, whether you have insomnia or not, you have a risk factor for premature heart disease. So let's adopt that from the American Heart Association, the AHA, and implement it for our sleep hygiene as well. So now the exercise should not take place in the evenings. I don't need you all of a sudden coming back from a 20-minute cardio at 10 o'clock at night, right? So that's a no-no, but you've got to incorporate it as part of your lifestyle. Is the question?
Not a question, but I know that part of proper sleep hygiene is also shut off your electronics, maybe a half, I don't know the amount of time, but I know that really can, the lighting is not good for you. Exactly
right. That includes even the TV in the room, right? So if you're going to watch TV in the room, have a wind down period. Charge your cell phones outside of your bedroom, right? Again, the adage is that the bedroom is only for sleep and sex. That's it. Nothing else takes place in your bed. I don't need you doing taxes in your bed. I don't need your brain making an association between any activity and bed other than sleep and sex. That's it, right? So that associative learning is called classical conditioning, and your insomnia may be a behavior that is classically conditioned. So let's break that link. Let's break that association. In bed, only sleep and sex, period. Anything else?
I have a question. One of the reasons I enrolled in this class, because I'm working with clients who report, complex trauma. male and female, maybe 80%. And all of them report, insomnia or nightmares, difficulty sleeping, right? Now, what I observed is that among the young adults, they don't like to take psychotropic medications. Their to-go treatment is medicinal or medical marijuana. So especially, most of them are on parole. So they have to do something with regards to their marijuana use. So the easy way for them is medical marijuana. And we know how easy it is, to get that. So any thoughts about that?
Yeah, so right now, unfortunately, if you look at the medical literature, there really is no indication with regard to behavioral health or psychiatry that would indicate the use of medical marijuana, right? So certainly wasting syndromes, right? So end-stage cancer, end-stage AIDS, certainly anorexia, where people, because of perhaps end-stage cancer, simply cannot eat any longer, have no appetite as a result of their medical illness, glaucoma, all of these have indications for medical marijuana. But they are clearly medical and not psychiatric illnesses. In the medical literature, right now, we just do not have the basis to prescribe or even support medical marijuana for any mental disorder, much less insomnia. And I would be very concerned that getting someone high so they can get a good night's sleep, quote unquote, is something that you might get tonight, but you will pay for fivefold, tenfold down the road. That would be a significant concern of mine. And if I'm already talking about when we're stopping a medication, when I'm ready to prescribe things like Ambien, things like trazodone, you better believe that conversation is going to have a much higher volume when I substitute medical marijuana for the Ambien. So that would be a significant concern of mine.
How do they pay for it down the road with the medical marijuana for sleep?
Well, one thing in the literature that we have seen is that use of cannabis does predispose to future mental disorder. Panic disorder, anxiety disorder, paranoia are all sequelae of chronic cannabis use. So that's something I'd be very concerned about, especially in someone who is younger than 25 years of age, where their brains, their plasticity has not been yet completed. That is, your brain is still in development up until and including age 25. That would be a concern.
I work in a large medical facility. I'm the resident LCSW, and I can't tell you, I have people in their 20s through 40s who were calling up because of panic, anxiety attacks, that all these same things, and they'll tell me they're daily marijuana smokers, or marijuana calms me down, or like people that kids that, adults that were on ADHD medication, they're like, well, I have to smoke marijuana all through high school, college, it calms me down. So and then I go, well, how is that working for you? You're calling me because you're crying. These are like men and women in their 20s and 30s. They're crying, they're panicking, they're anxiety, but they can't stop using marijuana. It's like a crutch.
Yep, exactly what it is. And unfortunately, it could even be a gateway. So you have to be very, very careful. I try to make a differentiation because, again, they ask for this in the hospital too. And we don't have medical marijuana on formulary in a hospital. So it's not even a discussion that I could entertain, even if I thought there was evidence basis for it. But one of the things I try to do in discussing what is likely to be the behavior once hospital discharged is that you have to make a distinction between being high and being free of anxiety. I mean, if the reason why you are anxiety free is because you're high from smoking, well, that intoxication effect is always going to wear off, and you are going to be right back to square one when it comes to your anxiety. The cannabis is not helping, exactly right. It's not helping your anxiety disorder, and is likely worsening it with regard to chronicity. So that's the differentiation we have to make. Unless you really feel that you're going to go through life baked and a chronic cannabis user, don't use the cannabis. And by the way, if your plan is to go through life baked, so that you can always
Beads.
be free of anxiety because you're always high. Don't do that. And, we get into a discussion about that.
Yeah, it's hard. It's just hard to convince people of that, especially
Extremely.
and not even just people in their 20s or even teenagers, like 19-year-olds, people in their 30s and
100%.
40s even.
Yeah. Now, again, I want to make sure I'm fair. There is emerging evidence in the literature that substances of abuse, illicit substances, are showing incredible results with anxiety disorders. And they include LSD, they include DMT, they include ketamine, and they include psilocybin. So I don't want to sound like that generation and therefore casting cannabis into a light just because I'm not open-minded. My mind is focused on the medical literature. And if the medical literature tells me that hallucinogens are working and cannabis is not, that's the only thing that I feel comfortable conveying to a patient. So half the story is that cannabis really right now has no medicinal use in the field of psychology or psychiatry. And oh, by the way, the hallucinogens might, right? They're emerging, and these trials look incredibly encouraging, and it's only a matter of time that LSD, DMT, and psilocybin join ketamine as a new age type of drug to address anxiety and other mental health conditions.
I think ketamine was the thing that police carry. When you said that, it rang a bell.
Okay.
That it may be something some police
Interesting.
carry.
Okay.
I don't know if it's injectable.
It is injectable, yeah.
Yeah, because I've heard of an overdose of somebody with ketamine with police.
Oh, okay.
Yeah,
Interesting.
yeah. So it was ketamine that I couldn't think of.
Quick question,
Thank-
why would police be giving medication?
I'm not sure about the ketamine. I don't know. It's the first time I'm hearing it. I know that they carry the naloxone, the naltrexone,
Right,
because of the overdose.
Right.
Because we're in the midst of an opioid epidemic. I don't know the other medications that they carry. It's new to me. It's interesting.
The police would be, if there was somebody having a psychotic break, like the person I was saying was running around naked and the mother didn't know what to do. So she called the police and said, I don't know what's wrong with my son. So that may, and
but the police, I would think, would take them to crisis and not give them medication themselves. Do you know what I mean?
yeah, I think they typically don't, or they shoot them.
They should
Try to put him in handcuffs.
Now, what if, with all best intentions, the review of sleep hygiene doesn't work? Then what? Well, the next step is to keep a sleep log, right? The idea here is to focus on sleep efficiency. What are the number of hours spent in bed? And what are the hours that one sleeps? And when you put the hours that one sleeps over the hours they spend in bed, that ratio should equate to 1, right? I mean, it'd be great if your head is the pillow and you're out, right? That's the goal. Now, the mere fact that a patient will be presenting to us with concerns or complaints of insomnia, we understand that that sleep efficiency ratio reaching 1 is something we're shooting for. Having said that, the practice is that when they're in bed for 20 minutes and they're still up, they get out of the bedroom and they don't go back to bed until they feel tired. And when they go back to bed, if in 20 minutes they are still up, they get out of the bedroom. Now, this can occur, this back and forth can occur throughout the entire night, day 1. But day 2, things are going to be a little better. And day 3, even better yet. Down the line, they will reach a sleep efficiency close to 1. But it's not going to happen overnight. You have to reassure your patient that this is something they're going to have to work at. This is going to take work. And when they get out of the bedroom, they should do something boring. They should not do something stimulating that would defeat the purpose. So again, no cardio. They've got to do something mundane and boring. Folding laundry is what I usually recommend. An insomniac should never fold laundry during daylight hours. They should always leave it to be part of that sleep efficiency exercise. So that's a behavioral approach to insomnia. And it's one that, again, occurs over months, okay, not just days. Either when this fails, or even in conjunction with this, a referral to CBT would also be indicated. Right? Now, if the patient is employing really good sleep hygiene, if they are bringing in their sleep logs that are calculating sleep efficiency, and they are attending CBT sessions, that is when I feel comfortable prescribing a medication, right? Because then in close contact with the CBT provider, we'll make a determination about when that stop date of that prescription will be. So that's part of the real concentrated treatment plan. And you could see how doing something like that is significantly different than just getting a script and delaying the discussion of how long we'll treat, maybe at a later date. We'll get to it when we get to it. That kind of practice, unfortunately, doesn't work. I have one more thing I want to make sure we cover here in the last 5 minutes, and that is, hey, doc, you tell me stay clean from drugs. You tell me that alcohol disrupts normal sleep architecture. So even the occasional glass of wine with dinner is something that I should avoid. You tell me to stop drinking coffee. What I will tell you is that they are my vices, all right? And that goes for nicotine too. You tell me that nicotine can actually keep me up. And when nicotine goes to lowered levels in my bloodstream, the craving can actually wake me up. So you're telling me to quit my pack a day. You're telling me no more alcohol. You're telling me no more coffee. And you're telling me no more use of drugs, no more experimenting, no more recreational use. Doc, I'm coming to you for insomnia. What's going on here? Any thought on how to address this problem? And by the way, doc, I've been drinking coffee since college, all right? I'm in my 50s now. The insomnia I've been struggling with for about a year. And alcohol, I've drinking a glass of wine with dinner for as long as I can remember, doc. How do you address this conversation? So there's two things. One is I want to make it abundantly clear. I am not diagnosing you as an addict. Far from it. It has nothing to do with our conversation. I'm not talking about a substance-induced mental disorder either. I'm not saying that the cause of your insomnia is the alcohol or the cocaine, etc. You do not have an alcohol-induced sleep disorder. You do not have a stimulant or cocaine-induced sleep disorder. Even that's off the table. But what I am doing is telling you that if you truly want to get a good night's sleep sooner rather than later, it is time to do a cleanse. And the organ that we have to cleanse is your brain. We have to get your brain to its native state before you begin abusing it, before you begin filling it with all these drugs, which, by the way, literally tens of millions of people do in our country alone. I get that. But tens of millions of people are not coming to me asking for help for their insomnia. You are. And if I'm going to prescribe a drug, I could tell you right now, the only way we give this drug, whether it's called Ambien, whether it's called melatonin, whether it's called trazodone, it does not matter. But the only way we get this drug, its best chance to work and work soon, is to have your brain as pure as possible. If you agree with that, we should work towards how to get you off the cigarettes and what I can do to help get you off alcohol. However, if you don't want to hear this, and if you want to keep your brain in its current state, I will tell you, this drug that I'm prescribing to you, I don't care what it's called, has an uphill battle. And if that's okay with you, then I'm okay in prescribing it. Right? So that's the conversation to have. We literally have 1 minute to go. Well, I could stay later, of course, but with 1 minute at 2:59, what questions can I address for the group in closing?
Are you doing the benzo class on Friday by any chance?
No, I'm not. No, that's not me.
Okay.
No. I think we did benzos at the beginning of this year, or maybe it was last fall. Again, we kind of take chance of peace between Stephen King and Disney. The benzodiazepine lecture is on Snow White. I think that was maybe last fall. Snow White's about benzodiazepine use.
It's a 3-hour class. I signed up for Friday, so.
I'm sure it'd be great, but not me.
Are you doing another movie cinema thing next month?
I think yes, December, I think is Home Alone.
Oh, it's a good one.
Yes, it is.
For Christmas, that's a good one.
Yeah, I think Disney has its fingerprints on that, so it's officially a Disney film. Yep, so it'll be Home Alone. I think it's the dissociative disorders. And by the way, if you've watched Home Alone, this is a perfect time to rewatch it even before our seminar, because there is a fan theory attached to it that makes it a very interesting fictional case study of dissociative disorders.
Dr. T, I don't know if you saw, I think it was on 60 Minutes last week. This is a little bit tangential, the use of magnets for the brain in order to try to really break through resistant depression. Have you had any experience with that or any thoughts about it?
Yeah. So transcranial magnetic stimulation is the gold standard when it comes to magnet therapy. And yes, one of my closest colleagues, someone who was my medical student, I was able to convince to go into psychiatry and become a psychiatrist. She actually went for OBGYN first, realized that she made the wrong choice, came back to psychiatry and trained in our program. And then recently, in April, teamed back up with us and is hired now by us, is starting and directing what is called a neuromodulation unit. So she is one of the real preeminent docs in transcranial magnetic stimulation. That's Dr. Graber. She is going to be the director of the new neuromodulation unit, which will be here in Piscataway. And yes, there is significant efficacy for depression in general and less than significant efficacy for treatment-resistant depression. So it's not quite as good as ECT, but for treatment-resistant cases, it acts as an intermediate that, with regard to better than meds, but not quite as good as ECT. So it kind of works in that middle area with regard to effectiveness for depression.
Thanks.
Anyway, if there are more questions, I'll hand you back over to Ricky. I want to thank everybody for their participation today. It was great.
Thank you.
Thank you, everybody. See you next month.
Thank you.
Thank you so much. We appreciate you being here. For everyone, I did send out the evaluation, so you'll have them in your emails. If you could take some time to complete them, and within 1 week, you should receive your certificate for attendance. So thank you.
Thank you, everyone.
Thanks, Ricky.
No problem.
Thank you.